Good evening, consultants, fellows, and colleagues on the call. Welcome to today's meeting. Today, we start our meeting with a guideline presentation by Dr. George Ofosu on the cardio-oncology guidelines. He has special interest in cardio-oncology, so we are fortunate to have him to take us through this guideline today. And Dr. Ofosu, please, your audience.
All right, thank you, Eugene. And good evening, consultants and fellow colleagues. So today I'll be talking about cardio-oncology, and my talk is mainly based on the 2022 Esc Guidelines on Cardio-Oncology. Okay, so this will be my outline. There'll be an introduction, some definitions, and then classifications of chemotherapy-related cardiovascular toxicities. And then we'll look at how to recognize cardiotoxicity, how to risk stratify patients, the screening tools that we need, and then how to manage cancer therapy-related cardiac dysfunction. And then we end by looking at some key messages. Okay, so I'll skip these two slides. Okay, so this guideline is the first ESC guideline on cardio-oncology. And before this, there were no guidelines on cardio-oncology. So there were different opinions, but this guidelines has come to streamline some definitions and then way of managing patients with cancer patients who have cardiovascular diseases. Okay. It also aims to help all healthcare professionals who provide care to oncology patients, either during, before, or during, and even after their cancer treatments, and for their cardiovascular health and overall wellness. Again, this guideline provides guidance on various definitions, how to make diagnosis, treatment modalities, and then prevention of cancer-related cardiovascular toxicities, and also management of cardiovascular diseases that are either caused directly or indirectly by the cancers. Molecular cardio-oncology has limited trials and evidence on which to base most of its decision. And where evidence is lacking, this guideline provides consensus of expert opinion. As we all know, nowadays cancers are detected early, and the early detection of these cancers in their treatments have led to marked improvements of patients with cancer. And this has also led to an increase in treatment-related complications. And cardiovascular diseases are one of the most frequent of these side effects. And these side effects may lead to premature morbidity and death among cancer survivors. Cancer therapy has been linked to myocyte damage, as well as LV dysfunction, heart failure, hypertension, and other conditions that we will look at in subsequent slides. These side effects involves the direct effect of the cancer treatments on the heart structure, as well as the function of the heart. And cancer therapy-related cardiovascular toxicities occurs in about 10% of patients. And these treatments may accelerate the development of cardiovascular disease, especially when patients already have the traditional cardiovascular risk factors such as hypertension, diabetes, and obesity. These side effects may be reversible, and in some cases they are permanent. And to avert all this, it's very important to do a risk assessment of patients before the treatment is started. And the management of these side effects have tremendous impacts on morbidity and mortality and the overall outcome of patients who have cancer. And the effective management of these patients with both cancer and cardiovascular requires a unique interest and expertise of health care providers. And this has led to the formation of this new discipline as the cardio-oncology discipline. And the goal of cardio-oncology discipline is to allow patients who have cancer to receive the best possible cancer treatments safely enough, and at the same time minimizing side effects throughout and after their management. Okay, so this cartoon basically shows some chemotherapeutic agents like alkylating agents, HER2 targeted therapy, tetracycline, taxanes. It shows their mechanisms of action and also shows various interventions that can be done. So that one will be looked at later. So for instance, if we look at anthracycline, it leads to cardiovascular disease by producing reactive oxygen species. It also causes DNA damage and also inhibits topoisomerase 2 beta. Topoisomerase 2 beta is an enzyme that is needed in DNA repair and is typically found in slow-growing cells like the myocardium. We also have topoisomerase 2 alpha that is found in fast-growing cells like the skin, the hair, and also in the cancer cells themselves. So tetracycline also inhibits these enzymes and doesn't spare the topoisomerase 2 beta that is found in the myocardium. So when this happens, it leads to LV dysfunction. The taxanes, they inhibit microtubule assembly and leads to impaired cell division and subsequent cell death. So all these various actions, when it happens in the heart, leads to LV dysfunction, can lead to heart failure, it can lead to hypertension and arteriosclerosis, which are mainly due to the vascular endothelial growth factor inhibitors. So cardio-oncology has so many functions. One function is to monitor for early cardiotoxicity and intervene. Another function is to also do a primary, secondary prevention of cardiotoxicity. It's also responsible to investigate suspected cardiac invasion by tumors and also for pre-operative assessments of cancer patients before surgery. All right, so now we look at some definitions. So in the past, there's been various terminologies and definitions that were proposed, and this led to inconsistencies in making diagnosis, as well as the inconsistencies in the management of these side effects. So CTRCD, that's the cancer therapy-related cardiac dysfunction, was broadly used to cover asymptomatic cardiac dysfunction and symptomatic heart failure that is attributable to the various cancer therapies. And this includes the chemotherapy, immune therapy, as well as radiotherapy. And current definitions of the CTRCD is now based on reduction in the LVEF and or a relative change in global longitudinal strain. So cancer therapy-related cardiovascular toxicity. This mainly refers to all these conditions that are listed. So when you have vascular toxicities such as coronary artery disease, peripheral artery disease, TIA, stroke, venothromboembolic events that occur as a result of cancer therapy, they are all termed as cancer therapy-related cardiovascular toxicities. and also includes arterial hypertension, arrhythmias, QT prolongation, pericardial diseases, pulmonary hypertension, and valvular heart disease. So the patient did not have any of these conditions prior to treatment and develop any of these whilst on treatment or after their treatment, then it's classified as a cancer therapy-related cardiovascular toxicity. This table shows some of the definition that existed before the current guideline from ESC on cardio-oncology. So the first one, okay. So the first one was from the American Society of Echocardiography and European Association of Cardiovascular Imaging. And they defined this as 10% decline in the EF to a final value that is less than 53%. And usually this value have to be confirmed. After the first assessment, it has to be confirmed 2 to 3 weeks. And if the value is still 10% less than the baseline, and the current value is less than 53%, then that's confirmed therapy-related cardiac dysfunction. Or when you have a reduction in the GLS of more than 15% compared to the baseline GLS figure, then that will also qualify for a cardiac dysfunction. But in this case, if the EF was normal and the GLS dropped by 15%, then that will be classified as a subclinical cardiovascular dysfunction. And then again, the US Food and Drug Administration also had this definition of a greater or equal to 20% absolute decline in the ejection fraction compared to the baseline, which also qualified as a chemotherapy-related cardiac dysfunction. Or when you have a drop of greater or equal to 10 compared to the drop or equal to 10 in the EF to less than a lower limit of normal. So in this case, there was no figure given for the lower limit of normal. So that would depend on the region and their cutoff for normal, or an absolute value of less than 45%. Okay, and there are various other definitions. So looking at these various definitions, it's clear that there were disparities in the cutoffs. So we'll now look at the current definition by the ESC. So this definition classified CTR-CD to two broad groups, those that are symptomatic and those that are asymptomatic. So starting with the asymptomatic, they are also grouped into mild, moderate, and then severe. So starting again with the mild, to classify a patient as having mild asymptomatic CTR-CD, first of all, the patient should not have any symptoms. And they come to do an echo, and the ejection fraction is 50% or above. That means the ejection fraction is normal. But you do a global longitudinal strain analysis, and their GLS have dropped by at least 15% compared to their baseline GLS. Or when cardiac biomarkers are done, and you have a new rise in their cardiac biomarkers, then this will qualify as a mild asymptomatic therapy-related cardiac dysfunction. But to be able to do this, patients should have had a baseline GLS and also should have had a baseline cardiac biomarkers such as BNP, NT-proBNP, troponin T, or troponin I, either of these four. But in the absence of these biomarkers, in the absence of a baseline GLS, then an absolute GLS can be used. So a normal GLS is between -18 and -22. So if a patient has a GLS that is less than minus 16, and there's no baseline to compare with, that can be classified as a low GLS. Okay, then we move on to the moderate. The moderate asymptomatic. So again, there should be no symptoms of heart failure. And when an echo is done, they have a reduction of at least 10% to an EF of between 40 and 49%. Okay, so that alone will qualify as a moderate asymptomatic CTR-CD. Or when the EF drops, but in this case, it drops less than 10 percentage points, but still to an EF between 40 and 49%, then you need an additional parameter. In this case, the same GLS or cardiac biomarkers. So if you have these two, then the patient will qualify as having a moderate asymptomatic CTR-CD. And for the severe, you only need the ejection fraction. So once the EF is below 40 and patient has no symptoms, then they are deemed to have a severe asymptomatic CTR-CD. Okay, so we'll move on to the symptomatic ones. So for those ones, they will clearly have symptoms of heart failure. And they are grouped into mild, moderate, severe, and very severe. So for the mild ones, they usually have mild heart failure symptoms. And these are those that do not require any specification of their heart failure therapy. So for those ones, they are classified as mild symptomatic CTR-CD. And those with moderates are those who need outpatient investigation of their diuretics and heart failure treatments. So these patients are having symptoms, but not serious enough to warrant admissions and can be managed on OPD. They are the moderate symptomatic ones. Severe ones are those that have the symptoms and will need hospitalization to be optimized. And the very severe ones are those who come with hypotension or in shock and will require inotropic support, and as well as those who need mechanical circulatory support, or in extreme cases, those who need cardiac transplants. So they all fall under patients with severe CTR-CD. Okay, so now how do we classify cardiotoxicity? So it can be classified into acute, subacute, and chronic. And this is based on the timing with regards to when it happened, with reference to their treatments. So acute cardiotoxicity occurs during the therapy or a few days after, a few hours or days after the therapy. Is the rarest of the toxicities, occurring in about 1% of patients. And this usually manifests as arrhythmias, AV conduction abnormalities, prolonged QT intervals, pericarditis, and myocarditis. And then we have the subacute cardiotoxicity. And this also occurs in about 1.6 to 2.1% of patients. And this usually occurs within the first year of therapy. And the chronic one, which is the most common, occurs in about 1.6 to 5% of patients, as cancer patients on chemotherapy. And this occurs anywhere after 1 year, and may even occur up to 10 years post their therapy. So this also emphasizes the fact that it doesn't end, monitoring doesn't end after the chemotherapy is done. But cancer survivors have to be followed up for many years for cardiovascular involvement. All right, so now how do we recognize cardiotoxicity? First of all, patients have to be well educated to know what symptoms to report. Otherwise, they may have these symptoms, but may not report to the hospitals. And we also need a good clinical history and clinical examination. So in the history, there are certain important points to note, as well as the physical examination. And in the history, we should be able to identify the presence or absence of pre-existing cardiovascular diseases. And this will also help us institute primary and secondary prevention. The examination mainly focus on identifying signs of cardiovascular diseases. So this table also shows where we should emphasize in the history and physical examination. So one key point is the patient's demographics. We need the patient's age, because age is a key factor when it comes to cardiovascular dysfunction and cancer therapy. Sex and their genetics also very important. We should also evaluate their cardiovascular risk factors, such as hypertension, they have diabetes, they have dyslipidemia, they have CKD, are they obese or not? And then again, we need to find out whether they've had chemotherapy before, and also their lifestyle risk factors. Do they take alcohol? Does patients smoke? ECG, transthoracic echo, and cardiac biomarkers abnormalities should also be elicited. So to do all this, we need risk stratification tools. And one key one that is used in this context is the Heart Failure Association of the ESC, which is in collaboration with the International Cardio-Oncology Society. So these two organizations have come up with a risk classifying tool that is used to categorize patients into various risks, as either patients who is at low risk, those who are at moderate risk, those at high risk, and those at very high risk. So there are a lot of parameters to consider. So we are starting with the age and their cardiovascular risk factors. So for instance, if you have a patient who is more than 80 years and is going to be on anthracycline, then the patient is classified as being high risk. So on this table, the H represents high risk, the M is medium risk, and we have M1 and M2. So basically, we are trying to assign values to their risk, and at the end, we get a total score. And based on this score, then they'll be classified as either being low, moderate, high, or very high risk patients. And this assessment is very important because it helps know how frequent patients should be monitored, and also whether they need any dose adjustments or whether they need any cardioprotective therapy before or during their chemotherapy course. Okay. So for the same age, for patients between 65 and 74, if they are going to be on vascular endothelial growth factor inhibitor, that will give them a risk of M1. So that will be a score of 1. So this is done for hypertension, CKD, presence of proteinuria, whether they are diabetic, dyslipidemic, and whether there's a family history of thrombophilia. So there's another table, and this one focuses on cardiac imaging and biomarkers. So for all patients who at baseline have an EF that is less than 50%, already they are at a high risk, regardless of whichever therapy they are going to be on. And those with EF between 50 and 54 are all at a moderate risk, the score of 2. And the same can be done for cardiac biomarkers when it's available. Okay, so under table for previous cardiovascular diseases. So we should assess whether the patient has heart failure already, or they have severe valvular heart disease, whether they've had MI or PCI or CABG in the past. Do they have angina, arterial vascular disease, or an abnormal ankle brachial index or pulmonary hypertension to be able to assign them the score. So if you have a VH, means patient is already at a very high risk, even with just a single parameter. Okay. So based on this risk classification, patients are classified as low risk. So when they are at low risk, it means there is no risk factors as listed above, or have one moderate, one risk factor. So for patients in this category, their future cardiovascular risk is less than 2%. That is very low. And for these patients, usually the advice is to continue with their cardiovascular surveillance as appropriate according to local, national, and international guidelines. But usually at low risk, the surveillance is the most minimal. So that they will follow the regular review schedule for cancer patients. And for moderate risk, are those whose total risk are between 2 and 4 points. And for these patients, their future cardiovascular risk is higher, between 2 to 9%. And they usually will require a closer monitoring of their cardiovascular health during treatments. And we should also consider referring them for cardio-oncology and cardiology assessment. And then for high-risk patients, those who will score a point of at least 5% or have any high-risk factor. And again, their risk is also much higher, between 10 to 19% of developing a cardiac toxicity. And for patients with very high risk, these are patients who have any very high risk factor, and they have the highest future cardiovascular risk of 20%. And for patients in this group, as the high risk and the very high risk, should be referred for cardio-oncology if available, or cardiology assessment. And the reason is to optimize the management of their pre-existing cardiovascular disease and modifiable cardiovascular risk factors. And for these patients, there must always be a multidisciplinary team discussion required for to satisfy a balance between treatment efficacy and the treatment safety. And where possible, switching to a less cardiovascular cancer therapy is required if patient is said to be at a high or a very high risk. Okay, so still on the baseline cardiovascular risk assessment. So after evaluating the patient for their cardiovascular risk factors, taking their cardiovascular disease history, their cancer history, and their cancer treatment history. And ECG has a class 1 indication for these patients. And ECG is done mainly to identify the presence or absence of arrhythmias, and also whether patients have prolonged QTC. Okay, so if they have a prolonged QTC, then we need to look out for the precipitant and correct them. And these patients should also be referred for cardiologist assessment. Again, ECG can help us identify suspected cardiovascular disease. And also with physical and metabolic assessments, it helps us to identify new or untreated, uncontrolled medical conditions, and also patient's lifestyle and presence of cardiovascular risk factors. And when these are identified, an aggressive management of these risk factors and existing cardiovascular disease has to be done. And this should follow the Esc guidelines and has a class 1 indication. If we find any present cardiovascular disease or if your patient is at risk of chemotherapy-related cardiovascular dysfunction based on their cardiac biomarkers, in this case, the troponin and the natriuretic peptides, when they are high, or when their EF is low or their GLS is reduced. So in this case, if the GLS is below 16 at baseline, the patient has to be referred for cardiologist assessment. And this has a class 1 indication. Okay, so this table basically is just what has been discussed already. So based on this risk assessment tool, patients who are low risk should have routine oncology follow-ups and cardiology referral if they develop any cardiovascular toxicity. And this is a class 1 indication. Those with moderate risk will need a closer oncology follow-up. And we also need a cardiology referral as a class 1 indication. And those at high and very high risk should always be referred to see a cardiologist. And discussion of their risk-benefit balance of the cardiotoxic anti-cancer treatment needs to be made in a multidisciplinary team discussion. And for these patients, cardioprotective strategies should be started. Okay, so still on the same thing, so I'll skip this slide. Okay, so this shows the recommendation for general approach to cardiotoxicity risk categorization. So cardiovascular toxicity risk stratification before starting potential cardiotoxic anti-cancer therapy is recommended for all patients with cancer. And this has a class 1B indication. And communicating the results of the cardiovascular toxicity risk assessment to the patients and other appropriate healthcare professionals is also recommended as a class 1C indication. And the use of the HFA-ICOS risk assessments tool should be considered to stratify cardiovascular risk in patients with cancer who are scheduled to receive cardiotoxic anti-cancer therapy and has a class 2A indication. And it is recommended that patients that are categorized to be at low risk of cardiovascular toxicity risk should proceed to anti-cancer therapy without any delay with a class 1 indication. So the rest, I think we have discussed those already, so I'll skip to the next one. So next, we'll look at how to screen and monitor the patients and what tools are needed to do this. So the first and the baseline one is ECG, electrocardiogram. And this is a common thing that's procedure that is common and can be done almost in every hospital. So a baseline 12-lead ECG can provide important clues to underlying cardiovascular disease. This will tell us about the patient's heart rate, will tell us about the patient's rhythm, whether there are any ischemic changes, whether there are any conduction defects, whether there is evidence of hypertrophy or not. And also give information about previous MI. And a baseline ECG is recommended before starting cancer treatments, especially if the treatment is known to cause QT prolongation. And performing ECG for all patients at baseline is has a class 1 indication. And in patients with abnormal ECG, referral to cardiologists is highly recommended. Another parameter is cardiac biomarkers. And by cardiac biomarkers, we mean troponin IOT, BNP, or NT-proBNP. This is needed for chemotherapy, related cardiovascular risk stratification. And there isn't much literature on these biomarkers in terms of the cutoff to use. So information on this is mainly based on experts' opinion. So patients with cancer with an increased troponin before treatment are more likely to develop CTR-CD. And baseline for natural uric peptide and or troponin is recommended in all patients with cancer who are at risk of CTR-CD. And that is highly recommended if these biomarkers are going to be used to monitor the patients during their treatment regimen. So another parameter is cardiac imaging, which plays a vital role in identifying patients with subclinical cardiovascular disease. And the imaging techniques help determine the degree of pre-existing cardiac comorbidities and also serve as a reference for the identification of changes during treatment and also during the long-term follow-up of the patients. However, the frequency of this imaging monitoring should be individualized, and this will be based on their risk level, whether mild, moderate, or high or very high risk. That will determine how frequent this imaging will be done. And early recognition of early recognition of asymptomatic CTR-CD to allow clinicians to incorporate cardioprotective therapy before there is any significant decline in the ejection fraction. So that the imaging modality that is recommended as first line is transthoracic echocardiogram. And this provides quantitative assessments of both the left ventricle and the right ventricle. It can provide information on chamber dilatation as well as LV hypertrophy. Again, it can also provide information on wall motion abnormalities, diastolic dysfunction, valvular heart disease, can give information on pulmonary artery pressure and pericardial diseases, which other imaging modalities will not provide. So still on the echo, the other imaging modality on the echo, which is AI-based, is the global longitudinal strain. So as said earlier, GLS, a normal GLS is anything between -18 to -22. So what GLS does is it's able to track the individual heart muscles and determines their level of contraction during systole. So it's based on this reduction that the machine will put figures to the various segments. You know, we have the left ventricle has 17 segments. So the GLS will basically provide values to each segment. So the more negative the value, then the more not normal, I should say, that segment is. So for instance, here we have -21, here we have -16, -14, and on this side we have a positive figure. So when you have positive figure, it means there is akinesia on that part. And you also see color changes depending on the figures. So when the figure is normal, then the color will be red. And as it becomes abnormal to blue, then we have akinesia. And to do GLS, usually we'll use three apical views: apical 3-chamber, apical 4-chamber, and then apical 2-chamber. So for this images, this was done at baseline for the patients, and at baseline, patient had an EF of 60%, a GLS of minus 19.9%. So at baseline, the EF was normal, GLS was also normal. And then during the treatment, so this patient was on trastuzumab. During the 11th cycle, the GLS had, sorry, the EF had dropped to 56%, which was still normal, but the GLS had dropped from minus 19.9 to minus 14.2. So if you compute it, had dropped by more than 15%. So it had dropped by 28%. So these patients had an normal EF, but a GLS that had dropped by more than 15%. So this patient is said to have a subclinical CTR-CD. And patient was started on cardioprotective medications and evaluated at the end of therapy and had ejection fraction recovered as well as the GLS also recovered to normal. So this is to emphasize the use of GLS in the monitoring of chemotherapy patients. Okay, so cardiovascular toxicity monitoring in patients who receive anthracycline. How often should they be monitored? Using ECG, using echo, and then using their cardiac biomarkers. So again, as said earlier, the frequency of this monitoring depends on their risk, the level of risk. So for the low risk patients, so for all the risk factor levels and baseline, they need ECG, transthoracic echo, and biomarker may be considered. So for low risk, these three, especially first to ECG and the echo as class 1 indication, and may be repeated before the 4th cycle of anthracycline, and also repeated 12 months post therapy of anthracycline. For those who are at moderate risk and on anthracycline will again have it at baseline, and echo may be repeated before the 4th cycle, and also 12 months post-treatment. So the main emphasis will be on those at high risk and very high risk. So these patients should have this kind of ECG, and their echoes should be done for every other cycle. So before every 2nd cycle, they should have an echocardiogram assessment, and also should have cardiac biomarkers done. But the biomarkers should be done before each cycle. And this will help identify subclinical cardiac dysfunction if present. Okay, so the same information, this time showing the class of recommendation and level of evidence. So baseline echo is recommended in all patients with cancer before doxycycline chemotherapy with a class 1B indication. And in all patients, in all adults, patients receiving anthracycline chemotherapy, an echocardiogram is recommended within 12 months after completing treatment. And in high and very high risk patients, echo is recommended every 2 cycles and within 3 months after completing their treatment. Okay, and then in moderate risk patients, additional echocardiography should be considered after a cumulative dose of 250 milligrams per meter squared of doxorubicin or its equivalent. Okay, so this one, cardiac biomarkers have been mentioned already. So now look at patients who are on human epidermal growth factor inhibitor 2. Example being Herceptin. So for those at low risk, And also for those at high and very high risk, should all have ECG, echo at baseline. Cardiac biomarkers may be considered at baseline. For those at low and moderate risk, should have echocardiogram done every 3 months and also 12 months post-treatment. For high and very high risk, they should have echocardiography done every 3 months and at 3 months post-therapy or the chemotherapy treatment and also 12 months post-therapy. And thereafter, the frequency will depend on their risk after the regimen has been completed. So this means that after the chemotherapy treatment, patients have to be risk stratified again. And at the end of therapy, patients may be at low risk, moderate, high or very high risk. And based on this risk after therapy, then the frequency of their monitoring will be determined. Okay, so still on the imaging, can also do cardiac MRI. This is mainly recommended in patients who have poor echo windows, and that's even when the MRI is available, then it should be considered. So apart from MRI, you can also do multi-gated absorption nuclear imaging. And this is a third line modality. And it's only recommended if transthoracic echo or cardiac magnetic resonance imaging are unavailable. However, the MUGA scan should be avoided whenever possible. And this is basically due to the radiation exposure and the fact that it's unable to give much information on valvular heart disease and GLS and pulmonary artery pressures as compared to echo or MRI. So recommendations of cardiac imaging modalities with patients with cancer. Echo is recommended as a first-line modality for the assessment of cardiac function in patients with cancer. This has a class 1 indication. GLS is recommended in all patients with cancer having echo cardiography if the GLS facility is available. This also has a class 1C indication. And MRI should be considered for assessment of cardiac function when echo is unavailable or non-diagnostic due to poor echo imaging. And MIGA has a class 2B indication. So when CTRCD is confirmed, how do we proceed with management? So now we're looking specifically at patients who have had CTRCD from anthracycline therapy. So again, they are grouped into symptomatic, and then asymptomatic CTRCD. So we'll start with the asymptomatic mild. So as a recap, the asymptomatic mild are those who have no symptoms. They have a normal EF, but their GLS have dropped by more than 15%, or baseline GLS less than 16, or they have a new rise in troponin I, troponin T, or BNP or NT-proBNP. So these patients will have to continue their anthracycline with monitoring and has a class 1 indication. And these patients should also be considered for cardioprotective treatments. In this case, we use ACE inhibitors or ARB and or beta blockers. Okay, and if the diagnosis was based on an increase in natural reactive peptide, then cardioprotective therapy may be considered. Those who have severe or moderate asymptomatic CTRCD should have their treatment interrupted. And this is highly recommended, and it's a class 1 indication. they should be assessed by a multidisciplinary team, and heart failure treatment has to be started for these patients. And those who are symptomatic, either mild, moderate, or severe, should all be on heart failure therapy. Those with mild symptoms should have an MDT discussion regarding interruption or continuation of their chemotherapy. Regardless, the heart failure treatment should continue. Those who have moderate symptoms should have their therapy interrupted, go on heart failure treatment until their EF recover, and then putting them back will have to be reconsidered by the MDT. Those with severe and very severe symptoms should have their treatments discontinued. Heart failure should be treated and should have an MDT discussion on the way forward. Okay, so the level of evidence, heart failure therapy is recommended for patients who develop symptomatic CTR/CD during cycling therapy. So all these have class 1 indication. Discontinuation of prostacyclin chemotherapy is recommended in patients who develop symptomatic severe CTR/CD. And temporal interruption of prostacyclin chemotherapy is recommended in patients who develop symptomatic moderate CTR/CD, and a multidisciplinary approach regarding the decision to restart is recommended. Okay, so now we'll move on to patients who have developed CTR/CD whilst on the HER2 targeted therapies. So this is similar to those on anthracycline, but with subtle differences. So the asymptomatic patients who are in the mild group, just like the AC, will have continuation of their therapy. And if this was diagnosed based on reduction in GLS or troponin or natriuretic peptide, then ACE inhibitor, ARB, and or beta blockers should be considered. Those with moderate asymptomatic should continue their therapy, but will have to start heart failure treatment. So unlike those on anthracycline who had moderate treatments, they had their treatments, they should have their treatments interrupted. But with Herceptin, treatment should continue when they are moderate symptomatic. For those with severe symptomatic, should have their treatment interrupted, should have an MDT consideration, and heart failure treatment should be started. For symptomatic group, they all should have heart failure treatments. And those with moderate to severe should have interruption of their treatments until their heart function recovers. Okay, so all that has been mentioned has one indication. Okay. So what is the trajectory for the heart failure treatments? Which patients can have their treatments de-escalated, and which patients should continue their treatments, heart failure treatments, uninterrupted? So patients who develop CTR/CD during cancer treatments and are being started on heart failure therapy. So this is an algorithm to follow. So we'll start from this side. So those who are mild or moderate, we need to consider whether they have recovered fully from the heart failure or whether they have had partial or no recovery from the heart failure. So on the left side, if heart failure has recovered fully, then there has to be an MDT to consider weaning patients of their therapy. And whether or not to wean patients off will depend on their risk level at the end of the therapy, that's the cancer therapy. So if at the end, patient is said to be at low risk of future cardiac toxicity, then we can consider weaning them off their heart failure treatment. However, if they are at high risk, even at the end of the treatment, then heart failure treatment will have to continue as a class 1 indication. On this arm, if recovery is only partial or there is no recovery, then let's continue heart failure therapy. And for patients who developed severe and very severe CTR-CD, their heart failure treatment will have to continue. So now we now consider patients who develop hypertension during their cancer therapy. So hypertension may be caused by the cancer therapy, especially patients who have put on vascular endothelial growth factor inhibitors like cisplatin. And it can also be due to non-cancer treatments like NSAIDs and steroids. So patients who have cancer most often will have pain. And for those who are put on NSAIDs as risk of developing hypertension, hypertension may also be developed due to stress, pain, and also due to sedentary lifestyle in cancer patients. And many cancer therapies that cause hypertension also cause cancer therapy-related cardiovascular dysfunction. And ACE inhibitor or ARB are the first-line therapy recommended and also to reduce the risk of CTR-CD. So for patients who have cancer and hypertension or who have cancer and develop hypertension during their treatment, the first-line antihypertensive should be an ACE inhibitor or an ARB. And a combination therapy with an ACE or ARB and a calcium channel blocker is recommended if patient's BP, stool BP is above 160 or the solid BP of above 100. So ACE inhibitor or ARB as first line antihypertensive drug for BP management in with cancer as a class 1B indication. And dihydropyridine calcium channel blockers are recommended as second line antihypertensive drugs for patients with cancer with uncontrolled blood pressure. This also has a class 1C indication. And combination therapy for patients with BP of 160, 110 and above has a class 1C indication. However, drugs like diltiazem and verapamil are not recommended for treatment of arterial hypertension in patients with cancer. And this is basically due to their drug interactions. Again, patients who have very high BPs, they are present with BP of 180 and above or diastolic of 110 and above should have their cancer treatments withheld until BP is treated and the blood pressure is below 160 over 160 over 100 before putting them back on their cancer treatments. Okay, so again, patients who have resistant cancer-related hypertension should have spironolactone or an oral or transdermal nitrates and or adolazine added to their baseline treatments. Okay, so all this has been said already. And during the treatment of hypertension in patients with cancer, what are the targets? So this is a recommended threshold for symptomatic hypertension treatment in different clinical scenarios. So these are the various scenarios. Patients cancer survivors, patients with curable cancer during treatments, patients with metastatic cancer with prognosis of more than 3 years, and patients with cancer with prognosis between 1 to 3 years, and then patients with metastatic cancer with prognosis that is less than 1 year. So we need to consider these clinical scenarios as against their home blood pressure figures to decide whether or not to treat them. So if a patient has systolic BP of above 160, regardless of their scenario, the class 1 indication that the BP should be treated. And if a patient has a systolic BP of between 140 and 149, then they have to be treated unless their prognosis is between 1 to 3 years. Then the treatment may be considered. Treatment has to be considered. And if prognosis is less than 1 year, then we may or may not treat the BP. Okay. So now look at cancer-associated thrombosis. So these basically are the VTs and ATs, venous thromboembolic events, and arterial thromboembolic events. And these are associated with cancer as well as its treatments. And cancer is said to confer about 5-fold higher risk of VTs and a 2-fold risk of arterial thromboembolic events. And venous thromboembolic events are the second leading cause of death in patients with malignancies. And they may actually be the first clinical sign of malignancy. And usually when patients have VTs, it's often followed by about 5% incidence of cancer diagnosis during the subsequent 1 year. So with the therapy, anticoagulation therapy, patients with cancer have both an increase in thrombotic as well as increase in bleeding risk. And this is in reference with specific cancer, reference to their location. So patients with GI cancers or intracranial cancers have both an increase in thrombotic as well as increase in their bleeding risk, as well as patients with thrombocytopenia also have increased risk in both bleeding and thrombosis. Several large randomized controlled trials and meta-analysis have shown that low molecular weight heparin decreases the risk of recurrent VTEs by about 40% when compared with VKs, but with similar risk of major bleeding. And VKA is characterized by an unpredictable anticoagulation effect and a low time in therapeutic range in patients with malignancies due to their drug-drug interactions, as well as GI toxicity and liver dysfunction. So when it comes to management of VTs, the recommendation for the management in patients receiving anti-cancer treatments. So apixaban, edoxaban, and rivaroxaban are recommended for the treatment of symptomatic or incidental VTs in patients with cancer without any contraindication to these drugs. And these drugs have a class 1A indication. And the low molecular weight heparin are recommended for the treatment of symptomatic or even incidental VTs in patients with cancer who have platelet counts of about 50,000 microliters. This same treatment as the low molecular weight heparin in patients who have platelet between 25,000 and 50,000 microliters should have half dose. Okay, so I'll skip these ones. So for long-term follow-up in cancer patients, again, we have to look at their risk after the cancer therapy. So for those who, at the end of the therapy, the assessment shows that they are at low risk of future toxicities, should have annual risk assessments. And those at and should be referred to see a cardiologist in case they develop new cardiovascular symptoms. Those with moderate risk should see cardiologists if they have new cardiovascular symptoms, and they should also have transthoracic echo every 5 years. Transthoracic echo every 5 years should also be considered for cancer survivors, but has a higher indication for adults who have childhood or who are adolescent cancer survivors. And patients who have high risk or very high risk should have patient education as well as cardiovascular risk factor optimization. And these patients, due to their high risk, should have frequent monitoring. So the recommendation is to do a 2-yearly thoracic echocardiogram. Okay, so we'll now look at some of the key messages in this guideline. So cardio-oncology providers must have a background knowledge of cardiology, oncology, as well as hematology with interdisciplinary communication, which is very important. Guideline, a guiding principle of the practice of cardio-oncology is to minimize unnecessary cancer therapy interruptions, with the decision to do so usually based on a multidisciplinary discussion. And echocardiogram and blood-based biomarkers are the main methods used in the assessment and monitoring of cardiotoxicity. And a new recommendation supports the practice of continuing trastuzumab in patients with asymptomatic moderate CTRCD with an ejection fraction of between 40 to 49, whilst initiating them on cardioprotective therapy. And this therapy, as mentioned earlier on, includes ACE inhibitor or ARB and or a beta blocker. And there's a new recommendation that supports the practice of de-escalating cardioprotective medication in patients, in cancer survivors with cardiac dysfunction who are at a low risk of future cardiovascular events. And patients must always receive psychological support when needed. And clear and accurate information about their condition to play an active role in their managing their treatments. And this will also help increase adherence to cancer and cardiovascular treatments. So we'll look at a few +1 indications in this guideline. So one is the use of low molecular weight heparin for prophylaxis of thromboembolic events in patients with multiple myeloma, which we didn't talk about, and VTE risk factors. And treatment of VTE with apixaban, edoxaban, or rivaroxaban in patients with VTE and cancer as a +1 indication. Treatment with VTEs with low molecular weight heparin in patients with cancer and platelet counts of more than 50,000 microliters. Cardiac magnetic resonance imaging for evaluating patients with suspected AL or cardiac amyloidosis also has a +1 indication. And also look at a few +3 indications in this guideline. One is to avoid creative prolonging drugs in patients with cancer and hypertrophic cardiomyopathy, which we didn't cover in this presentation. Also to avoid aspirin in patients with cancer and thrombocytopenia if the platelet level is less than 10,000 microliters. And we also need to avoid clopidogrel in cancer patients with platelets less than 30,000, and also avoid prasugrel and ticagrelor if the platelets value is less than 50,000. Aspirin or low molecular weight heparin are not recommended for primary prevention of stroke or symptomatic thromboembolism in patients with cancer and atrial fibrillation. And lastly, diltiazem and verapamil are not recommended for the treatment of hypertension in patients with cancer due to drug-drug interactions. So these are my references, and I'll end here, and we'll take contributions, comments, or any questions. Thank you very much.
Thank you very much, Dr. Fosu, for such an excellent presentation. You made us aware cancer is being diagnosed early and management has improved over the period, and so people are living longer and are coming with side effects. And you stress on the importance of risk stratification for our patients on chemotherapy, especially with respect to their cardiac health. And you made mention of the HFA ICOS score for risk stratification, and that informs the risk of the patient and the choice of chemotherapy agents to use. And you discussed the baseline investigations in addition to history, physical examination, the importance of cardiac biomarkers, troponins, and echocardiogram measuring strain. And you brought us through to the definition of what LV dysfunction means in respect to chemotherapy and how to manage our patients. We are grateful. At this point, we open the door for questions. Kindly unmute and ask your questions.
Hello, good evening, everybody. Hello,
Good
can you hear me?
Yeah, good evening, Charles.
Good evening.
Yeah, Dr. Fosu, thank you so much. Thank you for a very well done presentation. Thank you for the effort, and thank you so much for delivering it excellently. I want to ask you a question on this on cardio-oncology. I don't know if you can give us, is there out of the drugs you mentioned, okay? Are there, you mentioned the anthracyclines, you mentioned Herceptin, you mentioned trastuzumab. I think there's one more you mentioned, I can't remember. So I'd like you to just list them up. That's this cardiotoxic cancer chemotherapeutic medication. Okay, if you can, then are there ones that are more dangerous than others? Do you understand me? Is it all of them, all medications used in cancer? Are there cancer medications that are safe or they are less cardiotoxic? Okay, that don't need these things. I just want to know. Thank you very much.
Okay, thank you very much. So as to the level to which these drugs can cause cardiotoxicity, they are not the same. I can't speak for any drug that doesn't have any effect on the heart at all. But with those mentioned, procycline, Herceptin, and the vascular endothelial growth factors, they are the key ones that mainly cause effect on the heart. The vascular endothelial growth factors usually causes vascular toxicities. So they will lead to coronary artery disease, peripheral artery disease, sorry, and hypertension. While the anthracyclines and the A2 inhibitors usually prone to cause cardiac dysfunction, but anthracyclines are known to be more hazardous than the A2 inhibitors. That's what I can say about the degree to which they can affect the heart. Thank you.
If I don't know how accurate this is, but I remember Dr. Fosu can clarify. With respect to the mechanism of injury or the mechanism underlying the cardiotoxicity, it appears the anthracycline methods are irreversible compared to the trastuzumab or the HER2. And that may be the reason why, if you look at the management for asymptomatic patients, for mild and even moderate patients on trastuzumab, you can continue medication as compared to asymptomatic moderates for anthracycline, where discontinuation is recommended. So in that sense, it appears that yes, the anthracycline should be more risky in terms of the risk of toxicity compared to the trastuzumab. But the anthracyclines are, I think, comparable to the taxanes, the paclitaxel and the others. But I think anthracycline is most in terms of risk. That's what I think.
Yes, yes. Thank you very, very much. That is very true. The anthracyclines are said to cause irreversible damage, as opposed to the Herceptin, that's the HER2 inhibitors, whose damage are reversible once the drug is withdrawn or treatment is done. Yes.
Thank you very much, George.
You-
Please, any other contributions, questions?
Hello, good evening.
Good evening, Adebayo.
Yes, well done. Thanks, Doc. Please, I have clarification as per the previous guidelines that have been presented on cancer and anticoagulation. Now, formally, I don't know, as if you discussed, is that in cancer patients, NOAC are contraindicated. But along the line, they said we can use a dosaban and one other one, I can't remember, maybe it's rivaroxaban in cancer, except those ones that has a GI cancer. Now, but in this presentation now, they made us know that NOAC is, they just generalize it. There's no exception to the rule. And they now added apixaban to the class of NOAC that we can use. I don't know. It's just a clarification. Is it? Because I'm just trying to retract to what I know before. That was the first one. The second one is on the use of aspirin and the lower molecular weight heparin in cancer patient that has AF, which at least maybe the second to the last slide that you mentioned that as if it's contraindicated. I don't know. That one was the second to the last slide that was presented before the end of the presentation. Those are the two things that I have. The other one is not regarding this presentation. I just want to seek the opinion of the other house as per their own experience. Is, I don't know, the IVF, people that have done IVF in the past and the risk of cardiovascular disease in them, because I've seen certain number of cases that in the later part of the second trimester, they usually develop hypertension. Their later fail to resolve even when they have delivered the baby. That's the third one. Thank you so much.
Okay, so to the first question, I think this table may answer that one. With respect to the recommendation for the NOACs, so as per this guideline, it said that apixaban, edoxaban, and rivaroxaban are recommended for the treatment of symptomatic or incidental VTs. That is when there is no contraindication to the use of the drug. And this is said to have a class 1A indication. This is highly recommended. I think the second question was on aspirin and low molecular weight heparin.
Yes. In AF. That was the second to the last slide.
Let me see if I can get it again. Is it here? Not on this slide.
No, second to the last, when you are doing the summary.
Okay. Okay, I think the point 4. Right.
Aspirin and lower molecular are not recommended for primary prevention of strokes or systemic tremor in patients with cancer and AF. Okay. It's okay.
Okay, thank you very much. So, in the absence of any other contribution, we go to our consultant on the call.
Sir, Dr. Eugene, sorry.
Yeah, Dr. Sorry, go ahead.
Okay. Good evening, Dr. Eugene, everyone. Thank you very much, Dr. George, for the very wonderful and clear presentation. I just want you to throw light on the use of beta blockers. I know from our previous discussions on MCQs, when you talked about tricycline-associated cardiomyopathies, I know they said the drug of choice from Bromwood and managing them is the beta blocker, particularly carvedilol or ACE inhibitors or ARBs. And also in your discussion here, there was a point you stated beta blocker as a choice and also ARB and ACE inhibitors. But when you went down to the guidelines, particularly, I don't think beta blocker was mentioned at all in the guidelines. And maybe I missed that point. When you go to the guidelines table, what they talked about was ARB, ACE inhibitor. Then when the blood pressure is above 160, calcium channel blocker comes in. There was no mention of beta blocker. So where do beta blockers come in management of cancer-related toxicity?
Okay, thank you very much.
Thank you.
So when it comes to beta blockers, one can be used as a cardioprotective medication when you have high-risk patients or when you have patients with subclinical LV dysfunction. And if you want to give cardioprotective medication, the first line drug will have to be ACE or ARB and or a beta blocker. And the beta blocker options include those that are recommended, the carvedilol and bisoprolol, carvedilol. Metoprolol is said to be neutral, so it's not recommended. But propranolol has been found to be rather harmful. So if you want to give beta blockers, it's carvedilol, bisoprolol, not metoprolol, because that one is neutral, but you avoid propranolol. When it comes to treating hypertension in cancer treatment, so in this case, it's not as cardioprotective mechanism, but for actual treatment, then in that case, the first line that is recommended is the ACE inhibitor or ARB. If you need to add on, then you go to the calcium channel blockers. If patients have resistant hypertension, then we recommend that you add spironolactone, nitrates, or hydralazine. So with the treatments, I think beta blocker was not mentioned. But to the steps of introducing the drugs, it has to be ACE or ARB, then calcium channel blockers, before spironolactone or nitrate or hydralazine. So with the management, I'm not very certain where exactly the beta blockers will come in, whether they have to come in after ACE or ACE or ARB and the CCBs.
Okay, thank you very much.
You're welcome.
Okay, so here we go to our teacher on the call, and Dr. Joe is on the call. Sir, good evening. And Dr. Adoyeji Stevens is also on the call. Good evening, sir.
Good evening, Dr. Yu. Good evening. Am I being heard? Good evening.
Yes, sir. You're audible, sir.
Yes, thank you very much, Dr. Eugene, and thank you very much, Dr. Oposu, for the presentation. I just want to add that what have been said in the presentation, but I would just want to add that apart from the ones that have been mentioned during the presentation, it's good to the catalog of all these chemotherapeutic agents and their individual cardiac side effects is very important for MCQ. So apart from the four or thereabout that was mentioned tonight, so the other ones like Christine, like 5FU, it's good to know each of these chemotherapeutic agents and their individual cardiac side effects for MCQ purpose. So by and large, apart from that point, it's a wonderful presentation. Thank you.
Thank you very much. Thank you. We have Dr. Ayodeji Stevenson. Good evening, sir.
Yeah, good evening, Dr. Eugene. That was a great presentation. Just to reiterate what Dr. just said, for MCQ and cardiac oncology, especially the different ones, and I yield, so you just need to pay special attention to it. With reference to GLS, CMR, and all that, so you need to know. That's all. But by and large, that was a great presentation.
Thank you very much, sir. Thank you very much. Once again, Dr. Fosu, we are grateful for doing this presentation. We are so much grateful. At this point, we'll end the first part and we'll continue with the Viva. We'll finish the remaining questions of the Viva and continue with the next set of Viva questions. So I'll log off and join. Dr. Okori can share if he has the questions and if he's in a position to share this evening. Otherwise, I'll join soon. Thank you very much.